Thank you for joining us today. We'll be presenting on the 3Ds, Delirium, Dementia, Depression. My name is Ioanna Genovezos. I'm the program manager for the Regional Geriatric Program of Eastern Ontario, and I have my colleague with me here today, Jennifer Coop, who's the Advanced Practice Nurse for Geriatrics at the Ottawa Hospital. So today we have no disclosures. We are not offering medical advice. This presentation is only for education purposes only, and we have no conflicts of interest to share with you all. Our objectives today for our presentation is really to go through an introduction of what delirium, depression, and dementia are. We're going to describe each one as well as the causes, risk factors, signs, and managements. And in order to dig a bit deeper, we're going to use a case study to review each of these different conditions and what we would do in each of the situations. We're going to do a comparison of all three and then do a case of a patient who actually has all three of those conditions at the same time. We're going to look at a collaborative approach, and then we're going to provide some tips on managing behaviors, which is always very critical with older adults who have cognitive concerns. First, let's start with some myths and facts. So in Canada, dementia affects 1 in 10 older adults who are 65 plus, and that number becomes 1 in 3 once adults reach the age of 85 and over. So we know that there are a lot of older adults who are being affected with dementia. By 2040, there's a prediction that 1.4 million Canadians will have dementia. We also want to make sure that we dispel the myth that dementia and depressions are not a normal part of aging. And also that the prevalence of delirium, which we'll talk about soon, is between 18 to 50% while older adults are in hospital. First, let's start with some basics about the brain. The brain is a very important organ that's responsible for how we think, how we feel, and how we act. We also talk about how the brain functions as the term cognition. So if you hear us referring about cognition, we're really talking about how the brain operates. As we age, the brain shrinks and blood flow decreases, but it's not something that we feel, and it really doesn't affect us in terms of our functioning and how we think. In dementia, however, there is damage to the brain cells, and the cells cannot communicate with each other. This then affects how we think and how we communicate and how we behave and how we feel. So in this image, we have the picture of a healthy aged brain on the left, so it has gone through some shrinking. And then on the right, we actually have a brain that's been affected with dementia. So you could see how there's a lot less matter that the individual has to work with.
Thanks, Ioanna. So next we'll talk about delirium. So our first D. So as Ioanna mentioned, delirium is very common in older adults, especially hospitalized older adults. However, it's not always recognized. Basically, it's a condition that comes on quickly and it affects our brain. It's usually temporary, but really needs to be treated right away. Most time, delirium is caused by a combination of things. So some of these causes include illness, so infection or dehydration, electrolyte changes. Pain can contribute to delirium. New medications or changes in medications, injury, poor sleep, constipation, lack of mobility, and often being in a noisy and confusing environment can contribute as well. So some of the risk factors are older age. Having depression, dementia, or delirium already makes the brain more vulnerable to delirium, and past deliriums also contribute to an increased risk for delirium. Having a broken hip and any major surgery is a major risk factor for delirium. So what does this look like? Often you'll see poor concentration, a lack of attention, difficulty remembering things, confusion, So new confusion or worsening confusion if it's a person who already has some cognitive impairment. Sometimes there are hallucinations or delusions, so seeing or hearing things that are not there. And then being very sleepy or slow to respond. Changes in personality is another one, and not showing interest in things, so sort of an apathy. And often with delirium, it can fluctuate. So sometimes someone may be more agitated, and other times someone can be very somnolent or very sleepy and difficult to rouse. So basically, as we get older, our bodies don't respond to injury and illness the same as when we're younger. So something like an illness like a pneumonia or urinary tract infection, where in a younger person you might expect to see a fever, or a cough, or if it's a UTI, a person may complain of burning or frequency with their urination. But often with older adults, especially those with these risk factors, the first sign can often be a change in thinking and behavior, and this indicates a delirium. Thanks, Ioanna. So to help illustrate delirium, we have a case study. So we'll talk about Bob here. So Bob is an 82-year-old man. He lives at home with his wife, and he had a fall, unfortunately, while walking outside. He fell and he fractured his hip. He came into hospital. He was admitted to orthopedics for his surgery, and it was successful. On day 3 after his surgery, he became confused suddenly and agitated. He was, picking at things and trying to get up out of bed, trying to leave the hospital. He doesn't know where he is. He's trying to get out of bed, and he doesn't recognize his wife. So what we see here is his risk factors are that he's an older gentleman. He's come in for a surgery. And surgery can be, as we mentioned, a very common cause of delirium. It's hard on the body. New medications during surgery, there's blood loss, there's immobility, there's constipation. Often people are not eating and drinking prior to a surgery, not sleeping. They're in this new hospital environment that's noisy. All of these factors contribute to a delirium. And so that brings us to this point. So what if what if Bob is your husband and he's in hospital and you're recognizing all of these things? So the big important thing is to get help. Keep in mind that you know your husband best. And when he's admitted to hospital, the healthcare team may not know all his background information in terms of how he was functioning and what his cognitive level was before coming into hospital. So they really need you to provide that information and to advocate for your husband. Let them know that this is a big change. This is not the way he normally is, and you need their help. So you will notice, that maybe Bob, his behavior is changing. So it's sort of like the brain becomes overwhelmed, and a fight or flight kind of reaction can happen for the patient. They want to protect themselves. They're confused. They don't know where they are. And so sometimes that comes through as a behavior and may be resistant to care, could even get aggressive, trying to keep people away, that kind of thing. So it's very scary for the patient and for family who's seeing this big change. So it's important to remain calm, try to reassure your loved one, ask for help, and be as involved as you can in their care to provide that comfort and that reorientation for your loved one.
Sorry.
That's okay. So what will happen, or what you can expect to happen, is that the healthcare team will start to do a workup to figure out what is the underlying medical issues that are going on right now that are contributing to these changes to this delirium. And so they'll want to do some blood work, maybe some other tests, maybe a CT scan of the head, things like that. And they'll want to ensure that your loved one is being hydrated well, that there's bowel regulation, that they're eating and drinking to the best that they can, that they're trying to mobilize the patient and manage pain. So all of those risk factors, we want to address them. Anything that we can alter and make better, we will do. And then as the caregiver, some things you can change is the environment. So ensure that the lights are down, especially at night. Try to remind the person where they are and that they're safe and you're there with them. You can, you know, have, obviously during COVID, visiting is very challenging, but if you can make a schedule so that you're there at important times like meal times, or maybe when the person tends to get more agitated, maybe in the evenings is when you can schedule your visits. Having soft music playing or bringing anything that's familiar that could provide comfort, even, you know, a blanket from home, familiar smells, things like that can really help provide comfort for someone who's experiencing a delirium. And then, you know, there's also ways that you can prevent this. So if you know your loved one's coming into hospital, there are things you can do. So make sure that they have their glasses and their hearing aids, because sometimes sensory deprivation can contribute to delirium as well. Have a clock and a calendar in the room so that they're able to stay oriented and have a sense of when day-night is and how many days they've been in hospital. Lighting is really important. You want to maintain that circadian rhythm and having lights on during the day and lights off at night, so it cues the brain and the body to when it's time to sleep. Keep them company. Understand that their brain is a bit overwhelmed, so you want to speak clearly, maybe a little slower, take things step by step instead of overwhelming with a lot of information all at once. Encouraging rest, sleep is so important. Eating well, staying mobile, making sure pain is managed, all of these really basic human needs, but that are very important and can help ward off delirium.
Thank you, Jennifer. So next we'll be covering a little bit about dementia. Dementia is a disorder of the brain that could affect learning, memory, mood, and behavior. It is a condition that develops very slowly over time, and it affects different people in different ways. Aging does not cause dementia, but the older you get, the more at risk you are for developing it. Dementia has multiple different signs, and there are varying degrees of dementia. So signs can be, for instance, difficulty performing familiar tasks. Familiar tasks such as something that someone does very regularly, for instance, cooking or preparing a certain meal. Difficulties with thinking, problem solving, or learning new things. Memory loss that affects day-to-day activities. And we know that memory loss evolves as dementia gets worse over time. So memory loss might be starting off with more recent memories. Things that happen in a day or within a couple of hours might be forgotten, but long-term memories take longer to actually be lost and are in the later aspects of the disease. There could be confusion about time and place, changes in personality, mood, or behavior, and also poor or decreased judgment. Now, these are all various degrees of symptoms of dementia, and just because an older adult may have dementia doesn't mean that they'll have all these signs. They might have a few of them, and they might get worse over time. So let's meet Sam. In this case study, Sam is a 76-year-old man who lives alone in his apartment and has a caring neighbor who helps him out. Now, the neighbor has noticed that the fire alarm has been going off at his house in the evening, and he went over to see him, and his house, he noted, was extremely messy, which is not like him. All the pots and pans were burnt, and there was spoiled food in the fridge. He also had not removed his garbage from his home in a really long time. The neighbor also noticed that he had a stack of mail that had been unopened on the coffee table, and his medications had been spilled all over the counter. Now, when we talk about dementia, we often look at not only how the person thinks, but also how they function. And in this case, we have a couple of flags coming up. So for instance, the fire alarm, his ability to cook, his ability to keep his house, the fact that he has spoiled food in his fridge, that the garbage hasn't been maintained, that he hasn't opened his mails, and he's probably not able to remember or follow through with taking his medications. So all these are significant signs that would point us to some type of cognitive impairment. So what do we do about dementia? So like I said before, we look at function. So function means basically how you do your daily tasks. There's simple tasks such as dressing, eating, and walking, and then there's more complicated tasks such as driving or banking. Now, depending on the degree of the dementia, it'll affect the level of functioning that you have. So if the stage is one that is fairly early, we're looking at those complicated tasks to be affected. And if the tasks are such as banking or driving, they're going to be impaired way before something as simple as bathing or toileting can be affected. So what makes a task complex or simple? So a complex task has multiple steps to it. For instance, grocery shopping. We might not think that grocery shopping is a complex task, as it's something we've been doing for most of our lives. But in terms of the steps that it takes to go from point A to point Z, there are multiple little steps that need to happen. For instance, you have to plan your trip, how you're going to get to the grocery store. And this is outside of COVID, so we're not really thinking about all the arrows on the floors and the masks and the hand cleaning, but just in general grocery shopping. You have to get there, get a cart, purchase the groceries that you actually need, go to the checkout line, put your stuff on the checkout counter, pay, take your groceries, take them home, whichever method you're able to, and then store them in the appropriate place. So that very oversimplified version of steps doesn't even account for planning, like what meals are you going to have this week, or what type of other foods are you going to have as a backup. So all these things describe complex behaviors, complex functioning. So something as simple as eating, picking up a fork and putting it to your mouth is a lot more of a simpler task. So as dementia evolves, the complex tasks are going to be affected before the simple tasks. And we also note that as dementia progresses, behaviors are going to be changing as well. So what do you need to do if this is your loved one? So the first step is always to communicate. Talk to your healthcare provider. This is an opportunity to get a diagnosis and explore treatment. The earlier you start flagging your concerns about your loved one, your friend, your neighbor, your parent, the easier it is to get the support that you need. And I think that's one of the critical things that we recognize, is that there is a need for education and a need for support. You also need to be prepared for the progression of the disease and how it's going to impact the person's function and behavior. That means that as the simple tasks start getting affected, living alone at home becomes more of a challenge. So you need to start planning for your future and for further support.
Thanks, Ioanna. So now for our third D, depression. So depression is a medical illness, and many people have experienced depression throughout their lives. Often it's a result of a major change or a loss. So death of a loved one, loss of independence, developing an illness. So some of the signs of a depression include sleeping more often than usual, a loss of interest or enjoyment out of usual hobbies. So if someone was, knitting and wanting to knit outfits for grandchildren, and then suddenly you notice they're not doing that anymore and not interested in continuing with that hobby, that could be an indication of a change that could be due to depression. Lower energy level, not being interested in taking on activities or going for that walk that they usually would go for. Eating more or less than usual. So you could eat less or more. So changes in normal habits is really what you're looking for. Difficulty concentrating. So depression does have an impact on cognition, just as dementia and delirium do. Aches and pains, so more like, we call them somatic complaints. So, a depressed feeling can also come through as, physical manifestation as well. constipation, being kind of preoccupied with bowel habits and things like that, being agitated, more irritable, so a change in their personality, feeling guilty, worthless, hopeless, regretful, a lot of negativity, negative emotions, and then thoughts of not wanting to live or ending one's life, so suicidal ideation, we can call that. So there's an acronym that we use in geriatrics and healthcare to identify and to assess for depression. We call it SIGI caps. So many of them have been captured here in the signs, but we assess sleep, loss of interest, G for guilt or low self-esteem, E for energy level, C for concentration, A for appetite, P for psychomotor changes, so that like restlessness kind of, and S for suicidal. So yeah, it's important, and really the whole point of this talk is understanding that the three can resemble each other in terms of delirium, depression, and dementia, and it could be misinterpreted as cognitive changes in a dementia, which impact thinking and behavior. So it's important to when you notice these changes, to really take note of what exactly is changing, what you're seeing. So for our case study, we'll talk about Sally. So Sally is an 80-year-old, recently widowed woman, and she lives alone in her 2-story home and has 4 loving daughters who all live nearby. Her husband suddenly passed away 3 months ago. She's been losing weight, she stopped cooking, which was one of her favorite pastimes, and she spends a lot of her time sleeping or sitting on her husband's recliner. She no longer leaves the house to go for her daily walks and prefers not to talk on the phone with her kids, and she feels she doesn't have the energy to talk to them. So as you can see, there's a lot of major changes that have happened since the death of her husband. The loss of weight, the, stopping cooking, which was something she really used to enjoy. She's sleeping more, and even, sitting in her husband's recliner, which shows that loss of her husband and that companionship that she used to have. She's not leaving the house, she's not walking, and she's not even reaching out to her kids as much. So this is really, a lot of indicators that are red flags going off that something's changed and we need to get help. So get help. So, I mean, the thing is too, whenever there are these changes in an older person's behavior and cognition, we want to do a medical workup as well to rule out things that can be reversible. So often, reaching out to your primary care provider is really important. And then of course, if there's a risk of suicide, especially, that's a huge red flag risk factor that needs urgent attention, to the point of, calling your family doctor or even going into a merge. So involving your doctor is really important. Some things they might want to do some blood work. So some things like your thyroid, they may want to check out your iron level, liver and kidney function, vitamin deficiencies. These sorts of things can impact your mood as well. So they'll want to do a medical workup like that as well. Then the treatments there are some medications, some pharmacological interventions for depression that can be tried. And then there's other non-pharmacological interventions, like going to talk about your issues and have that support through a counselor or psychologist or something like that. And then as whenever these interventions are put in place, you want to monitor to see if they're helping your loved one. Are they getting any more energy? Are they kind of coming back to who you know them to be? So other things that can be done to minimize symptoms is to encourage exercise. So going for those walks, getting out some fresh air, seeing nature, mindfulness. So, being present in the moment, thinking about what's good in the world, what's good in our lives, trying to focus on those things, having a good, healthy, balanced diet, getting enough sleep and good quality sleep is really important. Avoiding illness. Social interaction is just so important for all of us. And, you know, especially during this time with COVID, it's really challenging. This has been one of the biggest things that's impacting people, is this social isolation. We are social beings and we need that support and connection with each other. So this is a major risk factor, and also something to help heal too, is to try as much to have that social engagement, you know, calling on the phone, having FaceTime conversations, things like that. Music therapy can be really helpful for people, as well as animal therapy. All good things.
So after we've reviewed all of the 3 Ds, so dementia, delirium, depression, we just wanted to highlight how they all could look alike, sound alike, and act alike. And regardless of which one it is, it's your job as your loved one's advocate to say that something's wrong, regardless of if it's delirium, dementia, or depression, because you know them best. And so it's up to the healthcare providers and the specialists around to try to decipher which one it is. And often, you know, a dementia could look like a depression and vice versa, or a delirium could look like a dementia, or someone could have all 3. And it really takes that investigation and digging deep into knowing what is really wrong with the patient. Because we have often seen deliriums, these acute medical conditions that are misperceived as dementia. And if you think that the delirium is not there, and it's really that dementia, that chronic, slow progressing loss of brain tissue, we've just lost the opportunity to reverse the delirium. And we've just lost the opportunity to preserve the brain function for as long as we can. Same thing with depression. You know, a lot of the activities and interventions, you know, are great if the patient's able to able to go forward with treatment to help them get access to be doing things like mindfulness and exercise, because often patients who are in a very deep depression, they don't have that ability to initiate treatment. And what's really critical is that regardless of which D it is, you know, when patients present to the hospital or to treatments or to their primary care provider, you know, or to a clinic, you know, it's really hard to know what their baseline is. And that's really what we want as one of the take-home messages in this presentation, is what is their baseline? So when we compare all 3 of the Ds, they're all very different as we express to you. So for instance, when we look at the onset of how quickly the disease comes on and the duration, dementia is very slow and progressive compared to delirium, which could happen over hours or days. So what does that mean? That means that perhaps if someone has been forgetful over the last 6 months versus someone who in the last, you know, 4 hours or 24 hours has forgotten that they live with their wife and where their home is. Like, that's an acute change. So dementia in terms of onset is very slow and progressive, whereas delirium is very fast. It happens suddenly. And depression, it really can fluctuate. We're not quite sure, like, it depends on what's going on, but there could be a change in their mood and it could be persistent. Now, in terms of the course, we know that dementia is slow and progressive and not reversible. But delirium is short, reversible, which is very critical, and fluctuating. Like Jennifer had said, one moment the person can be confused, the next moment they're totally with you and able to have that conversation and recognize you. In terms of depression, we notice that in the mornings, usually it's worse, but it is reversible with treatment. In terms of alertness in dementia, alertness is usually normal until the later stages of dementia. With delirium, there could be fluctuations of their alertness where they're either falling asleep when you're talking to them, or they're really hypervigilant and, you know, have very short attention spans. Whereas depression, alertness is normal. When we talk about attention, usually with dementia, attention is intact. They might not always understand what you're saying, but they could always focus. Whereas with delirium, there's a lot of inattention. They are easily distracted and they cannot focus on the one thing you're asking them to do or talking about. With depression, Attention is minimally impaired, and often they have poor concentration, which is one of the SIGI-CAP signs that we look at. In terms of orientation, so that means knowing who they are, where they are, and what day it is. In dementia, it slowly gets lost over time, and knowing who they are is one of the last symptoms, one of the last things that they recall. In terms of delirium, it could be impaired or it might not be impaired. They might be very alert and orientated to what's going on. They might even be able to tell you, I don't feel like myself. And with depression, orientation can be selective, and there's a lot of apathetic answers like, I don't know. With memory, in terms of dementia, recent memory is impaired first, and then long-term memory is impaired later. With delirium, there could be impacts on recent memory, and with depression, memory could be selective or what we call patchy. When it comes to thinking, so another one of those things that the brain does, when it comes to dementia, there's often difficulty with abstract thinking and poor judgment. You know, thinking of the what ifs that happen, and that's very common in things that are complex like driving, right? When you're driving, you're not only driving the car, you're also anticipating things around you. With thinking with delirium, it's disorganized, it's tangential, it could be incoherent, and patients could be rambling, like they can just be very, very confused in that moment in terms of how they think. Whereas in depression, their thinking is intact. There's often themes of helplessness, rumination, and guilt. And lastly, with perception, so that means having hallucinations that could be visible or to touch or sounds. With dementia, it could be long-standing with conditions like Lewy body or in later stages of dementia. Whereas with delirium, hallucinations or illusions could be present, and with depression, they're often rare. So when an older adult comes to be assessed by someone who specializes in geriatrics, we really try to figure out which D are they fighting with and what does that mean for them. So here's an example of a case study. Let's talk about Mary. Mary, unfortunately, has all 3 Ds. So Mary's a 79-year-old lady who lives at home with her husband. She's been diagnosed with dementia 2 years ago. Her short-term memory has been declining, but with her husband's help, she manages to live well at home. Recently, she learned that her neighbor, and also who was her best friend, died as a result of a stroke. Also, on the same day, she told her husband that she felt her abdomen was hurting. Over the next week, she became confused, more than her normal. She is angry at her husband, calls him the marshal, and calls out for help. She's become incontinent of urine and refuses for her husband to change her. He also noticed that she hasn't had a bowel movement in a week, and she's foul smelling of urine. She cries in her sleep, and she takes small naps in the day and stays awake all night. So as we dissect this case, obviously, we know that there's an element of depression here happening with the loss of her best friend. We know that, older adults are more likely to have depression as they age because most of their circle does pass away, which is, the realities of life. But that sudden loss of her neighbor, her best friend, the person that she saw often, that's a big flag for us that there is some element of depression. There's also some issues here because we know she's been diagnosed with dementia, and we know that she's been living well at home. So these sudden changes of her ability to function, her abdominal pain, her incontinence, which is new, her being constipated, which is new, all these things are telling us that maybe there is also a delirium happening. Maybe the brain can't tell her that she has a urinary tract infection. She wouldn't have the normal fever, pain when she urinates, blood in her urine, and the only symptom we're getting is that she's acutely confused. She's also does not recognize her husband anymore. She's starting to call him a marshal, which is not something that's been normal to her, and she's been calling out for help. So this case, in this scenario, Mary really needs to come to the hospital and get some medical attention to figure out what is going on with her so we can reverse some of those urgent issues, such as the delirium. So trying to figure out, does she have a source of infection? Is her constipation affecting her ability to think? And then in longer term, we're looking at her being followed up for her potential depression, if her behavior continues, and also her dementia. So this is a very complicated case. And if you didn't know Mary's history and you were just meeting her today, you'd have a hard time figuring out if she has dementia, depression, or delirium. And this is why this talk is so important.
Thanks, Ioanna. So what we want to promote here is a collaborative approach. So recognizing that we're all working together, the patient, the person, their caregiver, their family, who's important to them, and the healthcare team, healthcare provider. And really the only way to move forward successfully is to work together. So something that's important to note is it can happen there. I mean, ageism does exist in our society, and what we want to avoid is just brushing off these things that we notice as being just normal part of aging. Oh, well, they're getting older, so it makes sense that they're, feeling down, or they're getting older, so it's okay to have a bit of memory problems. It's so important when we notice these changes to speak up, pay attention, and get help to look deeper into what's going on. The sooner we identify these things and take a preventative approach, the better. The more we can maintain function, the more we can optimize the medical situation that's going on, and the more we can preserve quality of life for our older adults. So, the other piece too is depending on the age of the person and, what generation they're in. Often, people from an older generation don't want to bother others, they don't want to cause trouble. And so it's so important for us as the people around them to really encourage that we pay attention and we take notice of what's going on. So for the patient, recognizing that the 3Ds are not a normal part of aging, they can have more than one at the same time, and that all behavior has meaning. So if we notice changes in how they're acting, something's going on underneath that. And sometimes it's the only way that communication's coming through, that something's wrong. For the healthcare provider, it's important they recognize that a delirium is a medical emergency and needs a workup to be done so we can treat the underlying cause. And once you treat the underlying cause, that helps the delirium to resolve. Although it may not resolve immediately, it often takes weeks, sometimes months, for the person to return to their baseline. But the sooner we address that underlying issue, the better the outcome we're going to see. And it's important too that the healthcare provider recognizes that they need that input from the caregiver to be able to identify what's going on, be that detective, pay attention to what's changed, and treat appropriately. And for the family caregiver, as we mentioned, it's important to notice the change and ask for help. Get help in figuring out what to do next. And as we said, we don't want to jump to conclusions that this is now their new normal that we're seeing, and making these big changes. They need long-term care, that kind of thing. It's important to first figure out what's going on here, and then use that to guide you in your planning for the future. And so we wanted to also include talking a bit more about behaviors, because this can be very challenging for both patients with cognitive changes as well as their family and caregivers and friends. So behavior changes are common among dementia, and also, like we mentioned, with delirium and depression. But with dementia, it's more something that we see that progresses along with the disease. There are physical changes, as Ioanna mentioned, in the brain that are happening, and as a result, there are changes in thinking and behavior. So something that kind of helps put it together is thinking about the ABCs of brain function. So if you think about your brain, you have your affective piece, so your emotions, you have your B, your behavioral or your actions, and you have your C, your cognition or your thoughts. And so a person with dementia has changes mostly in the cognitive piece that then impact the emotions and the actions especially. So for example, a person with dementia, let's say, soils themselves and they feel ashamed. And let's say there's a younger caregiver that's trying to change their clothes. So the emotion they're feeling is this shame about it. And so then the action may be that they hit or resist the person who's doing the changing because they feel ashamed and they want to sort of protect themselves. And then the cognitive piece is that they lack the insight or the understanding to be able to adjust their behavior dependent on the circumstance. So they don't necessarily put it together that this young person is their hired caregiver and it's their job to do this, and they're, you know, that it's not their fault that they were in right? Putting the whole story together, the person's not able, they just feel the emotion and then the behavior results. So they're missing that cognitive piece to put it together. Another way to think about the behaviors that we see in dementia, we have these 8 A's, we call them, and it's a way to describe the changes in the brain that cause these challenging behaviors. So some things that you may see are trouble with planned movement. So as Ioanna was mentioning, the grocery shopping, how are all of those steps involved? The same could be said with, you know, going to the bathroom or changing your clothes. As we get more advanced in dementia, you know, how do you know, sit up properly, remove your blanket, stand up from bed, go to where the clothes are kept, choose the appropriate clothes for the weather that's outside. And first you take your pajamas off, then you have to put, right? So there's a lot of steps involved that the brain has to do. And as the dementia progresses, these sequential steps become more challenging. Other things are, you know, there's a loss in ability to recognize objects, or you know, the loss of memory. They also have trouble reasoning or understanding that they have an illness, and so aren't able to rationalize that and understand why they need so much help. Trouble with language is another thing we see, or a misinterpretation of what they're seeing and hearing. And then having trouble initiating things as well. So there's a number of aspects of the brain that are affected in dementia, and it is progressive. So you won't see all of this at once, but over time you'll see these changes. So what can we do about it? So some things that really help are to pay attention to that emotion part, accept how they're feeling, right? Because that's what's driving their behavior, is what are they feeling? What's going on inside for this person? There's something that's triggering this behavior. So try to accept it and then try to understand what could be bothering them. And then try to adjust that thing that's bothering or treat what's bothering them so that hopefully this will provide them some comfort. Invite the person to join in activities. So instead of asking, do you want to go for a walk? Say, I'd love to go for a walk today with you. How about you come with me? And so you take on that initiation piece so that it's not too overwhelming for them. You're taking that on and they're joining you in the walk, and they'll certainly enjoy it, right? They're there with you, they're getting to move. Providing comfort with favorite items and activities that you know they enjoy. Trying to recreate a home routine. Routine is really important. Share what matters most about your loved one with the healthcare team. So these things that you know bring them comfort, try to recreate them, especially if they're admitted in hospital, because we know the environment there is not ideal. And then some things to avoid. So arguing, testing, and correcting. So like we said, with they don't have a full understanding of their illness, and so and also, you know, rationalizing and understanding. Oh, sorry. My apologies, there's an announcement at the hospital. And then also we don't want to force someone to do something. So, you know, if you've invited them to join you for the walk and you start going for the walk, but you see it's not going well, don't push it, you know, maybe try later on in the day. Try not to take things personally. You know, the behaviors are not coming with malice or an intent to, you know, hurt you or others. It's really very basic, usually has to do with protecting oneself or just, you know, overwhelmed with an emotion. It's not about you, it's what's going on for that person. Try not to choose activities or things that may be too challenging or overwhelming for the patient or person, sorry. It could be too much for them to do, and then if they're having trouble, this, you know, obviously causes maybe some, you know, discomfort for them and emotional changes, so then you'll see some behaviors because of that. And try not to ignore their concerns. If you see that there's this behavior change, try to figure out what's going on, because if you ignore it, it could make matters worse, and you could be missing something that maybe, you know, may need a treatment or you could have control over to make the person more comfortable. So those are sort of some helpful tips we wanted to put together for you.
And just to add to Jennifer's, you know, excellent tips on, you know, what to do, what helps and what to avoid. You know, these are really, you know, very simple, straightforward tips that have been proven to work in the literature. But we also recognize the challenges that, you know, some older adults face, you know, when they're with the person that they've been with for, you know, 40, 50 years, married in the same home, and, you know, there's a personality change and they're coping with all these changes, and, you know, maybe the reflex is to argue or to correct or to, you know, force them to do something because it's just not who they were before. And we know that that is part of the journey. So, you know, this is something that, you know, we might oversimplify in terms of, you know, how we manage behaviors, but we know the challenges that, you know, families and patients and their loved ones face, especially with COVID. And I think we didn't really touch very much on COVID. Jennifer did talk about social isolation, but we also, you know, want to make sure that, you know, there's also other challenges, you know, like not seeing your loved ones for a long time because of the stay-at-home orders, the impacts that social isolation has on the function of people and how maybe their muscles and their balance and their gait isn't as good because they've been staying at home and really fearful of leaving the house, and the impacts that this pandemic has in terms of, you know, how our older adults are coping, you know, given the context of, you know, what's currently our state. And we know that there's going to be long-term effects for older adults for because of the pandemic, but it really empowers us to share the knowledge on the 3 Ds in order to help caregivers provide care to those older adults and advocate for what's right and what's safe for them.
Yeah, great point, Ioanna. So thanks, everyone. That brings us to the end. Thank you for your attention, and we hope it was helpful, and we'd love to take your questions now. Thank you.